My name is Linda McGlone, and I'm the coordinator of the Strive Youth Violence Prevention Project at the Monterey County Health Department. We are delighted to welcome our speaker today, Dr. Lindy Knox, who is a founding director of LANET, a primary care practice-based research and resource network in LA County. She worked as a clinical psychologist for 12 years in healthcare and school environments in Texas, and is an associate professor of family medicine at the University of Southern California for 10 years. In addition to her work with primary care safety net practices, Dr. Knox is co-director for the CDC-funded Southern California Center for Academic Excellence in Youth Violence Prevention. Related work includes a project in which she served as a consultant to the government of Trinidad and Tobago on a $30 million initiative funded by the Inter-American Development Bank to improve public health and social services for families and children in 22 high-crime communities across the nation. Dr. Knox is also the lead developer of Madres, a promoter or promotora-delivered parenting intervention for high-risk children and their mothers. It's designed for Spanish-speaking and recently immigrated communities. Madres was developed in partnership with the community and Latino Health Access, a promoter-based health program located in Santa Ana, California. Lindy is the author of a variety of curriculum and the co-author or editor of 3 books and manuals: Connecting the Dots to Prevent Youth Violence, a training and outreach guide for healthcare providers, which was published by the American Medical Association; Beyond Suppression, Global Perspectives on Youth Violence, published by Prager Press; and Practice Facilitation for Primary Care Improvement, a how-to guide that will be released by the Agency of Healthcare Research and Quality this fall. Dr. Knox is a member of the Federation of Practice-Based Research Networks Steering Committee and serves on the board of directors for the National Health Foundation. Dr. Knox lives in Long Beach, California, with her husband and 2 children. I would like to welcome Dr. Lindy Knox. And as we get started, 2 bits of instruction. If you have questions, please type them in the chat box, and then we'll cover them in the end. Or Lindy, Dr. Knox, can also see the chat box if she chooses to address them as they come. At the end of the meeting, I'll also send the CDC analysis of parenting out to all of the participants. So with that, Lindy, welcome, and thank you so much. Take it away.
Hi, Linda. Thank you so much for that introduction. I'm realizing what I sent you, some of it's a bit out of date. I am no longer with USC. I actually left about 4 years ago to run LANET out in the community full-time. So, and I'm looking at this survey. This is the neatest thing. I've not gotten to do this on one of the webinars before. Thank you guys so much for joining me. And Linda has asked me to talk to you a little bit about our program that we developed through the Southern California Academic Center of Excellence on Youth Violence Prevention. The Academic Centers of Excellence, and I think you all are probably quite familiar with them with your work with Linda, but they were created about 12 years ago now, shortly after the Columbine school shootings. There were 10 originally, and the number has changed periodically since then. But their mission or charge was really to do several things. One was to partner with communities to develop comprehensive violence prevention plans, was to do research on both the nature and epidemiology of violence in the communities around the Academic Centers of Excellence, and also to develop interventions and spread best practices and evidence-based programs that had already been proven to be effective. And so this project, Madres, and the intervention that resulted from it, was out of that Academic Center of Excellence and was focused on the needs of the communities surrounding our particular center. So let me back up a little bit and just tell you briefly about me. So in my organization, we are a practice-based research and resource network. These are entities that were created by the Agency for Healthcare Research and Quality about 10 years ago. And they were really designed to push research questions and discovery and knowledge generation activities out of the academy, out of the university, and into the community where they would be led and driven by frontline service providers. So while our focus is mainly on primary healthcare providers in our network, we also partner with community-based organizations that provide mental health services, social services, promotor-based interventions, which Madres a Madres was the result of a partnership with a promotor social service program. And what our agency attempts to do, and ARC and HRSA also helped fund some of it, SAMHSA has been involved. We've been involved in a number of NIH projects also, including the National Children's Study. What these partnerships are really designed to do is bridge between the university and the bookshelves of the library per se, the evidence base that we've developed in academia and in research, and the frontline clinician and community members to be able to bring the two together to develop programs that are both evidence-based but also culturally sensitive and informed by the needs of the people in the community. So our organization, my organization, supports about 26 federally qualified health centers and community organizations, like our partner on this project, Latino Health Access, about 165 practice sites in LA and Orange County, about 1.5 million patient visits a year would be the type of kind of size of population that we're working with. About 70% of our patient population are Latino, many of whom are recently immigrated, many of whom are uninsured, and then also about 20% are African American, and then a population also of Asian Pacific Island communities and different groups as well. Just to give you a quick kind of view of our spread, again, the kind of organization I'm working in, we really are viewed as a pipeline for bringing innovation to primary care and other safety net service providers in the county. But we're also a pipeline for transmitting great ideas from frontline practitioners, be they mental health service providers, social workers, healthcare providers, community members, back into both kind of the federal conversation for the agencies that are funding these things, whether it's the CDC or ARC or SAMHSA, and also to local policymakers, and then in partnership to researchers at the various universities. If you all have questions as I'm talking, please feel free to also type those in to the chat box, because I'll take a peek at them and try to address them as I'm moving through. So a little bit about what LANET does, and this again is important so you understand the context in which this program was developed and how it was developed. We do practice and community-based research, and again, these are projects that are either direct partnerships with the community and the providers, or they're actually led and initiated by them. We find that many of the best ideas come from the front lines, and so we will help matchmake between those clinicians or kind of social activist groups in the community with a researcher in a university, or we will actually take the project ourselves and drive it forward. We also do quality improvement with social service organizations and primary care organizations, and much of that is focused around helping them implement evidence-based programs with fidelity in their own systems. And then the third one is really these patient partnerships in health, which is really about empowering the patient community, and we actually don't even use the term patient, but families and parents and children to become partners in health and partners in improving the quality of life and health of their communities. And so this again is where we begin to work very heavily with promotor and peer mentoring models. So Madres a Madres, to kind of give you a little background about that, we work, like I said, with a community-based organization in Santa Ana, and it's a promotor-based program. It's called Latino Health Access. They have about 61 full-time promotoras, and the promotoras are people that are recruited from the community who oftentimes have whatever the condition is that we're seeking to address, like diabetes. The promotores would have themselves lived with diabetes, either themselves or with a family member. With the parenting program with Madres a Madres, the promotores were themselves moms trying to raise their children in a very difficult context. And so one of the reasons and impetuses for Madres a Madres is that the parents in the community were very overwhelmed. It was mainly an immigrant community. Many of the parents were monolingual Spanish speaking. The children were quickly learned through some training that they would get in school about, I'll call 911, and they were able to intimidate their parents in a way not to discipline, partly because the moms were unfamiliar and the fathers were unfamiliar of Child Protective Services, and they were worried about getting called and their children being removed. This was also occurring not too long after 9/11. And so there was a great deal of tension in immigrant communities across Southern California, and a number of racist and retaliatory acts by people not from these communities on the community members because of the color of their skin or their ethnicity or their background. So we were also working within a context that was quite difficult, more difficult than normal. The ICE raids had started with a great deal of energy in that period of time. So many of the families had experienced the loss of a family member through an ICE raid. We had one child in particular that had a tachycardia event at school because he became so anxious that his parents wouldn't be home when he came back from school. We had parents making plans with their neighbors. If I don't come home today, can you do this to take care of my children? So this was a very difficult environment for these parents to be raising their children, working with their children in school. The rates of violence, even in a normal environment, were very high. About 15 active gangs in the area where we were working. Very high dropout rates when children were transitioning from elementary school to middle school, and then high teen pregnancy and also family violence levels. Many of the fathers would immigrate first to the U.S., and they would live maybe for a year or two by themselves, oftentimes being very stressed. Drinking would also become a problem, and then when the family would reunify, when the rest of the family would join the father, oftentimes that reunification process was also highly stressful. So this was the context that the mothers and fathers that we were working with in that community were dealing with, and the promotores were seeing every day as they worked out in the communities. And so the request was made to partner with them to develop a parenting program that would help them be more effective in working with their children. And kind of an interesting sideline about this, when I was first engaged, I went out and did this very elaborate presentation on, with GIS mapping of violent events and all this information on youth violence. And we had pulled together what we called a green team, which was members, families from the community who came together to talk about the problem of violence. And I talked and did my wonderful academic spiel at that time. And my background is actually as a clinical psychologist. I worked clinically for about 15 years before I got into research and policy. And at the end, you could just hear a pin drop, and it just, nothing was happening. And then when the conversation did start happening from the families, their concerns were about rats and roaches in their houses, and the moms having to stay up at night and leave the lights on because they were worried about rodents getting on their babies. And so there had been a shooting in the parking lot of the elementary school 2 weeks prior. But if you think about Maslow's hierarchy of needs, where the parents were living was even at an even more basic level. And so a big part of the initial development of this project was really understanding where the parents and the community was coming from. And that was where our partnership with Latino Health Access became so important, because they were really that portal that helped us rethink and helped me rethink the way that I was approaching the community and approaching this project. And so we spent an awful lot of time listening. And Madres began to grow out of those listening sessions that we had with the community. Another impetus for this program is we've actually received a request from the World Bank. And one of the things that they were interested in, and then our particular academic center became interested in, is how do you develop a program that's low cost, that's feasible to take to scale, that can leverage a local workforce or create a local workforce to deliver the program, and that builds and leaves behind capacity in a community, and while at the same time based on best evidence. So that is the challenge that we had when we began to look at Madres a Madres. And so we partnered between our Academic Center of Excellence and Latino Health Access. And with Latino Health Access, it was their staff. They have a full-time psychologist who's actually from Mexico, who's bilingual, bicultural, who really was my chief partner in developing this, with the promotores, and then with moms from the communities and dads from the communities. The process we went through to develop it was to do a review of best evidence, and I'm going to walk through that CDC meta-analysis that we relied on primarily in just a minute. We did interview and work with promotores and parents, and that oftentimes meant me just following and my staff just following people around in the community and getting to know them and listening. Creation of material with the staff of Latino Health Access, then piloting. The promotores themselves actually went through the program first. And I'll talk a little bit about how absolutely critical the training and supervision of promotor and peer mentoring programs is for these programs to work well. We then did a small pilot of the effectiveness of the program, and I'll show you the results of that. And then we also created a training program, a 20-module training program for the promotores. So I want to talk briefly. Linda had asked me to talk about the CDC meta-analysis that we relied on. And one of the big challenges is, how do you blend best evidence with community need? And how do you develop a program that addresses and incorporates both? And what we found when we first started working on this project was this wonderful meta-analysis that had been done by Linda Valle at CDC and a number of her colleagues that looked at research on parenting programs, parent training programs over the last like 10 to 15 years. And the goal of this project was really, of their meta-analysis, was to look not at which programs as a complete entity are effective and which are not. Like, are the Incredible Years better than the... Really, it was trying to tease out what are the active ingredients in effective programs that create that effect. What are the components of the programs that make them effective, that are the most effective? And so the meta-analysis looked at the content of the programs, for example, teaching communication skills or social skills, and then also the delivery methods, the lecture, the role play, the home visits. And we're really seeking to tease out, what pieces of this are the most effective within effective programs, with the rationale being that effective programs and components could be integrated into already existing parenting interventions. Ineffective strategies or content approaches could be removed, both as a means of saving cost and increasing effect. And for us, because we weren't starting from an already existing program, it gave us an opportunity to design Madres a Madres to parallel and be consistent with these, quote, active ingredients in the parenting programs that were found. They focused on, when they did the meta-analysis, they looked at 77 studies met the criteria for rigorous design. And then they were also looking at programs that, quote, actively acquire parenting skills. So they eliminated anything that had to do with stand and deliver lectures or relied solely on videos, since there's already a pretty robust evidence base that suggests these are really not sufficient to impact parent behaviors and attitudes in most instances. And so they focused on these actively acquired parenting programs. They also focused on programs that were targeted at children's age 0 to 7. Now, Madres a Madres, actually, we worked with children up to the age of 12. So we took some liberties there, but I think many of the principles that came out of this meta-analysis probably do track on to some of the older age groups. The outcomes that were tracked, the two things that they were looking at were improved parent behaviors and attitudes, and then decreases in externalizing behaviors in the children was their child outcome variable. The content, remember thinking about these active ingredients, the content categories that they were looking at was content on child development, knowledge and care, positive interactions with children, responsiveness, sensitivity, nurturing, emotional communication, disciplinary communication, different approaches to discipline and behavior management, teaching skills in that area, promoting children's social skills and pro-social behavior, and then cognitive and academic skills. So the content of these programs that they were reviewing focused on that. The methods that they looked at in the meta-analysis were interventions that were delivered by curriculum or manual, by modeling the person delivering, the professional delivering the program, or layperson delivering the program, modeling the desired behavior, homework assignments, things like rehearsal, role-playing, in-session practice, separate, pulling the children out for separate instruction, and then also the process of connecting families to ancillary services, to social services or health services or other types of resources. And remember, the two outcomes they were looking at were changes in parenting behaviors and then child externalizing behaviors. So they weren't looking at other outcomes like reductions in food insecurity or health status of the family. So they had a very tightly focused outcome that they were after. What they found from the meta-analysis is that there were three key components and methods that were associated with improving parent behavior the most and reducing child externalizing behavior the most. And these were teaching parent communication skills, teaching parents positive parent-child interaction skills, and requiring parents to practice with their children during the session. And most of these mapped to an intervention that probably most of you all are familiar with, the parent-child interaction therapy. And one of the things that they found in the meta-analysis is PCIT is what it's called in its acronym, was probably the most effective parenting intervention for that particular age group and outcomes by, I believe it was a factor of 2. And when you look at these components, can you see my cursor, or do I have to click, Linda, on this little button?
Yeah, if you click on either the highlighter or the arrow.
Okay, well, I probably don't need to do that anyway. I'll get fancy, but then I'll confuse myself. So the PCIT reflects each of these components, and that was one of the findings from this meta-analysis, is really that approach to parenting intervention in terms of the outcomes that I've outlined was the most effective. In terms of their finding, in terms of components that contributed to decreases in externalizing behavior, these 4 were found to be the active ingredients in these 77 studies that they reviewed. Teaching parents correct use of timeout, teaching parents to respond consistently to the child, and then back to what I just mentioned, teaching parents to interact positively with the child, so interrupting that coercive cycle and building that opportunity for the parent and child to have even just a few minutes out of the day that were positive, that did not involve teaching, discipline, redirection, those types of things. And then requiring parents to practice again with their child during the session. So when we looked at this meta-analysis, and I actually visited a number of times with Linda who led the meta-analysis, we started looking at how do we take what the community is telling us, the promotores know from their day-to-day work with their families, and then these findings from the meta-analysis and blend them into a program, and that's really what gave birth to Madres a Madres. So I want to, Linda, would you let me to pause and take a few questions, or go all the way through and then take questions at the end?
Lindy, I don't see any questions. I was thinking maybe a couple of points of clarification. When you talked about the child's negative behaviors, what exactly did you mean?
So the externalizing behavior is really the aggressive, acting out, oppositional, defiant types of behavior. If you all are familiar with the Achenbach child behavior scales, and they have an internalizing scale, which is really things like anxiety, depression, withdrawal. And then externalizing are the behavior problems, the acting out, the things that oftentimes form risk factors for later, health risk behaviors in young people. Those were the ones that this particular meta-analysis focused on. In our own work in the community, the focus on externalizing was less important because we were really viewing ourselves as a primary prevention program, and we're a universal program, so we were not just targeting children that perhaps were having problems at school, but we were open to anybody in the community that was interested in participating. So our program, the externalizing piece was, we weren't particularly focused on that. We were really looking at how do you build resilience, how do you restore that parent-child relationship. Does that address?
Yes.
I see a question. I just saw a question come up.
It's about obtaining
can we have
data
access?
analysis.
I will send you guys a copy of it. And there's a very nice kind of short summary that the CDC put out for practitioners.
And Lindy, I'd be happy to just send that to all participants. I have the link
I'll
for
send
that.
it on to you, and you can send it out.
Yeah, no, I'd be glad to, because it is really good and it's very readable, I thought. One other thing is, could you define PCIT one more time?
So parent-child interaction therapy is a particular approach to trying to strengthen the relationship between a parent and a child. And when I worked clinically, I used to work at child guidance centers, and I did a lot of reunification of children who'd been removed from the home for abuse, and then when they were being reunified with the parent. And the judge would court order PCIT as part of the reunification process. And of course, this was taking place in a clinical environment. And what it is really teaching the parent to interact with the child during a special play session in a way that they do active listening, but they do not teach, they do not question, they do not discipline the child. The only time they would interact in a disciplinary way with the child is if the child was going to harm somebody or themselves, and the parent would step in. So the parent was coached to really learn to follow the child's lead and then to use positive, active listening, mirroring types of communication skills with the child. For younger children, this would take place in a play setting. So you might have, the mom and the child and just a bunch of toys. And the mom would just sit and watch the child start to play, and then she might say, oh, you're picking up a block. Oh, you're building a tower. Oh, you're sitting thinking. And then she might start mirroring what the child does. And what this interaction does, this kind of structure creates, is an opportunity to interrupt. It's built on some of Bill Patterson's theories on coercive parent-child interactions and how that leads to abuse and just kind of stress in the parent-child relationship. It circumvents that. It sort of short-circuits it. And it structures a short encounter between the parent and the child that's positive. And so what happens is the parent begins to build positive affect toward the child begins to bond to the parent. And even if the rest of the day is chaos, they have that little island of positive experience with each other that over time really builds. And there's a second part of PCIT, which is the disciplinary piece that teaches positive discipline strategies and teaches things like timeout and how to go about doing that in a non-coercive and non-aggressive manner. We use these positive play sessions, and we delivered them through promotoras. So the program is actually designed to be delivered by psychologists and social workers and nurses, a professional population. And what we did was do a modified version, train promotoras to deliver it, and it was very, very effective. We would get stories from the parents just anecdotally, and we did some focus groups telling us it totally transformed their relationship with their child. They had told their child they loved them for the first time. Then they started describing how it was affecting not only what we called the focus child, because when we did the pilot, we had them. Many of our families had 5, 6, 7 children. They would pick one to focus on in the age range of 6 to 12. But they would start talking about how it had changed their interactions with their older siblings. And so we found this piece in particular, that and then the social network and connectedness that we created through the Madres Cafecitas to be probably the 2 most potent pieces. Does that address your question?
Yes, thank you so much. Thank you so much. I'm seeing we have a question from Francine Rod, and she's asking, it sounds like you made some, I don't want to say a leap, but you applied the information from the CDC meta-analysis, which was from children 0 to 7, to older children. And her question is about the difference between small and older children. I'm wondering, can you perhaps point us in a direction of, is there any similar study that looked at the older kids, or?
You know, I have not found a good meta-analysis of parent intervention programs for the older population, but obviously the PCIT changes because you're not playing with toys anymore. Usually you do art activities with them. And then the discipline strategies will evolve. So we were working with kiddos from 6 to 12. And so for the older ones, we started using, it's called 1, 2, 3 Magic, I believe is the name of it. And what that was really designed is to teach the parents consistency. And that was one of the things also in the meta-analysis. And there was a natural consequence that oftentimes came with the 3. And so we would start talking to the parents and train them, and they actually practiced in the session. We had little videos that they would watch that served as a form of modeling. And in an ideal model, we did the home visits when the children were in the home, but we found logistically that was just very difficult to make happen. So we oftentimes did a lot of this through role playing. But we used a program called 1, 2, 3 Magic, and it taught the parents to be very consistent in terms of their application of limits and discipline and natural consequences. And so there's a whole process of teaching the parent what a natural consequence is. What we found, especially in the families we were working with, is when they immigrated, there was more of a tradition of corporal punishment in the Latin American countries they were coming from. They would arrive here, become very alarmed about Child Protective Services, and so they would just abandon all discipline, and oftentimes move into a lot of verbal aggression with the children as kind of the only mechanism they felt they had to try to control the child's behavior. And so what we tried to do was reconnect with them in terms of here's another way to go about setting limits and providing discipline and consistency and structure and consequences for the children that did not involve verbal aggression or physical corporal components. So I don't know if that addresses your question very well, but we modified both the play sessions and also the discipline strategies based on the age of the parent and the child, and then what the parent was comfortable with.
Why don't I let you go on for the sake of time,
okay.
And then Francine, I'll try and pick up it sounds like I didn't characterize your question well. We'll try and pick that up at the end, as hopefully time will allow. So Lindy, go ahead.
Okay. So there's the findings of the meta-analysis. That's the findings on the, so now we're at, and I wanted to show you guys a quick video. Bill Moyers actually came out and did a piece not just on Madres, but it was actually on the whole promotor model and program that we're using in the Santa Ana area and partnering with Latino Health Access. They have a whole initiative around pediatric obesity. We've had a whole initiative going on about open space and creating parks. It was about 60,000 people in the zip code, and there wasn't a single park. There was one little pocket park, and the neighborhood around it had gentrified, and they'd actually gotten it zoned a passive activity park, which meant that you could sit on a bench and play theoretical basketball. So there was just no place for children to play and for adolescents to be. So you would drive around at night and you'd see the teenagers out in the street, in big clumps. Even the building managers would not allow the children to play in the courtyards of the building. So it was really a very, again, resource-poor, distressed environment. And so this work that is talked about briefly in this video, Bill Moyers came out and did a 30-minute piece on the parks that was aired on television, and then did this secondary piece that shows one of our promotores doing a Madres home visit. So do I need to do anything, or?
I will now hit the play button, and the magic of video will appear.
My name is Adali Robles. I've been a promotora for the Latino Health Access Agency for 3 years. When my children and I first arrived from Mexico, my son would cry every day because he didn't understand English. Well, he cried in here, and I cried out there. It's difficult for us parents. But having the support of so many people who are around me now, and who will be with me through whatever comes next, that tells you you're never alone. What we're doing today is a home visit with Mrs. Maria Castañeda. We're bringing her the Mothers to Mothers program. It's to provide her with information about brain development, about discipline, about how children change a lot during adolescence. It's a really great opportunity because we get to know the family home.
¿Te ha dolido tu pie? ¿Ya no te ha dolido tu pie? Oh, qué bueno. Entonces, como primeramente lo que vamos a hacer es a grandes rasgos, se llama el camino de la esperanza. Nosotros le pusimos que es muy diferente cuando tú dices.
It's very different when you say, I'm from the community. I live in the community. I know what happens in the community. Than saying, oh, I come from whatever place, so I try to imagine how you live. But I live the reality, so they can't fool me, and I can't fool them.
Algunas veces en algunas casas existe el problema de la violencia, la enfermedad del alcoholismo, de la drogadicción, y nuestros niños se ven muy, muy afectados, y sus neuronas no se pueden desarrollar, a tener problemas en la escuela, empiezan a meterse en pandillas y todo eso. ¿Cómo podemos nosotros ayudar a nuestros hijos a llegar a la universidad, que no se metan en drogas? Y si nuestros niños están bien, la comunidad va a estar más saludable. Entonces nosotros lo que queremos es que nuestros hijos vivan en una comunidad saludable. Que ya no vivamos en el 92701, que son la zona más violenta de la ciudad de Santa Ana. Queremos hacer un pequeño cambio.
Every single program the agency had, I was the first one there. My husband used to say to me, they're going to have to start paying you. I told him, but I like it. I told him I learn a lot here. And so later they offered me the job.
Tiene una planta, piensa que va a crecer ahí.
Ah, por eso dice que es suya.
Sí, pero no va a crecer, papá.
Es que él tiene la ilusión que
sí.
El día es bien importante cuando uno es niño, ¿no?
Sí.
Que siempre tiene la ilusión de que van a lograr.
Él piensa que va a crecer.
La otra vez platicando con unas personas.
Sometimes when you talk to people, they say, oh, the American dream is a house, a car. I tell them, for me, the American dream is to be a promotora. It's to be a promotora because the level of personal satisfaction I experience just doesn't compare. I tell them to be a promotora, you don't need a degree, you need a heart, and that'll start opening doors. I thank God that I found Latino Health Access, that they're working with me, and that we can move forward. And I do the same thing with the families. We share information, we find them resources, we work with them on that. That's it.
Okay, thank you. So that video was the woman that you saw is Araceli, and Araceli was one of our Madres a Madres promotoras, and she was actually very active also in the development of the Madres a Madres content, and then helping us modify it over time, and then worked very much out in the community with other mothers. And we, by the end of it, started having dads coming up and protesting because they also wanted to be involved. So we're actually now working on a Padres a Padres version. So just, I think most of you are probably very familiar with the peer mentor or promotor model. Peer mentors, oftentimes one thinks of as volunteers, but it's also a term, because the term community health worker and promotoras, not so much in the U.S. but in other parts of the world, can be a very political term. and imply certain things. Sometimes we end up using the term peer mentor, and sometimes we use promotoras. But the characteristic of it is somebody from the community who has a lived experience very similar to the individuals they're going to be working with. They're from that particular area, and they're able to share both knowledge that they learn through training, and then also their own life experiences, and become part of the social network of, for example, with our Mothers to Mothers, building a social network of mothers within these low-income communities, oftentimes within a building, because even much of the child care that occurred in our communities was taking place with moms dropping off children at the woman across the hall's apartment while she went out to go look for work, that type of thing. So oftentimes our intervention really was engaging not just the mothers in the building, but grandmothers, abuelas, people that might be doing informal child care, and became part of this kind of collective child raising resource. One of the things that we found very important, and I've learned all of this from America Bracho, who's the woman that started Latino Health Access, and she herself is a Venezuelan physician who worked many years in Venezuela before she came here and began to bring the community health worker model here in her work. But the promotoras, or the peer mentors, really need a great deal of support and supervision, because one of the things that happens when they become a promotor is they, even though they're from the community, they become different from the community. They become set apart in a certain way. And so they need extra support and training, because even though they're helping to lead this intervention, they're also become, in a strange sort of way, also isolated, because they're different now from their peers. So this program relies entirely on promotoras, who are then supported by this, I mentioned, the PhD psychologist who is at the Latino Health Access Agency, and she's bicultural, bilingual, actually grew up in Mexico. And she provides supervision and training for them weekly, very intensive training and supervision ongoing. So the Madres a Madres program includes threads. We call them threads. There's 4 sessions, because again we were doing something that was low cost, scalable, and flexible, both for low-income communities in the U.S. but also for spread internationally. And it provides an initial didactic component, even though that's not necessarily supported in the meta-analysis that we looked at, but kind of a baseline in terms of child development and helping parents, the moms, develop realistic expectations of their child's behavior. Oftentimes there's an attribution of negative intent where it's really just a developmental issue. And so there's training to help them in terms of understanding child development and appropriate expectations, but also in our community to develop a sense of urgency. There was oftentimes the feeling of, well, we can worry about that later. It's not important now. And so what we did was actually use a lot of neurobiology and brain development work and imagery to build the sense of immediate need to do something different or to enhance their child's environment and experience. And we found, of many of the things that we did, this was the thing that resonated with the parents. We have these flip books that they're a little bit like that. I don't know if you know the Peabody vocabulary. They're little easel books. And on one side is an image that the parent sees, and the other side is the script that the promotora follows, and then eventually they depart from it when they become much more comfortable. But the moms kept tearing that image, and you saw it in the video with Bill Moyers of the 2 brains, and they were putting it up on their refrigerators. And it was just an incredibly powerful intervention to get these mothers' attention and develop kind of a priority for change within them, just from that brief exposure to the neurobiology. Then there's a second thread that runs through all 4 sessions, which has to do with goal setting and aspirations. And this is really built around the idea of core competencies for children. If you go back to some of the resilience theories, what are those competencies that children need to succeed? And that means successful elementary school to middle school transition, middle school to high school transition, and then high school to college or high school to workforce transition and family. And so we teach the moms what those are. And we have like 5 or 6 competencies, and they learn what those are. And then we have parenting competencies. What are the things that you as a mother need to know how to do to be able to create these in your children? So there's time spent each week having the parents look at, I don't know if you know the conversation maps that they use for diabetes, but it's a visual aid to help teach oftentimes low literacy people, but they use it with everybody, really complex ideas, and you use this visual graphic. It looks like a road, and you have a little car that drives down the road, and at each intersection there's some kind of new teaching topic. So we use those kind of visual aids, and the mom actually has a little car that she drives down the road, and then we talk about the child competencies and the adult competencies, and then the detours, and those detours were tailored to that community, which were high crime, ICE raids, drugs, school dropout, teen pregnancy, those types of things. And the parent, over the period of these sessions, develops a strategic plan really for their child in terms of beginning to vision what do we need to be doing to get our child to that point in the end of the road, which is, for these moms, oftentimes college graduation, a good job, being able to be a spouse and have children, those types of outcomes that all of us want, right? And then the third thread is positive discipline, and this is teaching the nonviolent disciplinary strategies, the consistent disciplinary strategies, non-aggressive methods. And we use this 1, 2, 3 magic process. And I don't think that there's anything particularly special about the 1, 2, 3 magic other than for these moms, they were able to understand it very easily. It was fairly simple for them to implement, and what it created for them was consistency. And then the final piece, each thread, the final thread in each session was this 15 magic minutes. And the first session, the promotor actually models for the mom a PCIT type play session, teaches them the no teaching, no disciplining, directing, the following the child's lead and active listening skills. And then every session after that, they actually role play it. If the child's there, they'll do it with the child, but like I said, that didn't work out like we were hoping because the children were oftentimes at school or not available. So then the promotor will come and be the child, and she'll have toys, and then the mom will role play with the promotor. And we found that to be, parents liked it a lot, and then we found it to also be quite effective. Then building on the World Health Organization's interest and others was really the ability to drop in modules that met local needs. For example, many of these moms were talking about PTSD experiences and then also maternal depression, so we developed a module around maternal depression that we actually wove in as a 5th thread in each session, but it also can be delivered as a standalone module. And then once a month we had cafecitos, because the problem with the home visit model and this one-to-one model is that you don't build that social network of support, and that's we found quite vital for health in these families. And so we have these gatherings once a month where everybody who'd ever participated in a Madres session could come. And there's didactic sessions on parenting, there's a support group that meets, and there's also training on things like financial management. We had a toy and talent swap, so like somebody who could cut hair could trade that with somebody who was good at gardening, that kind of thing. And then I think I've already covered most of this. They're mainly delivered through home visits, although we're doing replications now with Orange County Department of Health. And also LA Care Health Plan is interested in also using this, and they're both asking for small group rather than home visit, mainly because you can serve more people in the small groups than you can through the home visit model. And the small groups are actually working quite well, and they're also giving us the opportunity to build those social networks. So the cafecitos become less vital because you're getting that in the small group meetings. Let's see, Linda, oh, there we go. We have, I'd mentioned earlier that we have the training for the promotores and supervision is just absolutely essential. And it has to be weekly, it has to be extremely high quality, and it has to address, because promotores are living the same experience of the people they're supporting, there's got to be a big Kleenex box in the training in the supervision room because the promotores are struggling with exactly the same issues. And so that supervisor and trainer really becomes the person that models with his or her interactions with the promotores, what you want the promotores to do with the parents in the community, which then you're hoping the parents in community will reach out and do both with their family and other mothers. We recruit in volunteers, so moms that have gone through the Madres program, then we will invite the ones that have a real passion for it or leadership skills, and ask them to come through the training. We pay our promotoras and employ them. Some people use volunteers. A quick run through on the pilot study. We've just done a very small pilot study. We had 235 mother-child dyads, majority of whom were very low income. We had family size ranging from 2 to 17, so quite a spread there. 95% of the mothers are from Mexico, so they were not born in the U.S. And we used just very basic surveys. I would do it differently. I don't think we asked a lot of the more interesting questions. We were still kind of stuck in our very academic thinking rather than what's practical. And I would have asked more information about, food insecurity and some of the context of these families as well. But what we did find is that there was a significant change in positive parenting skills, both knowledge of and use of, perceived support from family, and so building a cohesiveness in the family. And then with the children, we found no difference in the externalizing symptoms, but part of that is probably the age group and also because we had a universal sample. So we did not have very many children that were having aggressive behavior problems that were part of our sample. So that was the result of our pilot. And we're now having replications in Orange County. There's 500. We're contracted to serve 500 high-risk mothers as part of their mental health services. There's a New City Public School in Long Beach is implementing with their Spanish-speaking moms, and then LA Care is looking at integrating it into its wellness planning and services, wraparound services for its safety net providers, mainly the private practice folks in the safety net. And they've asked for a pediatric obesity module with theirs. So these are additional resources, and I'd be happy to take questions now in the few minutes we have remaining.
Oh, that's great. Lindy, thank you so much. That was really informative. I have a question here from Angelica Chavez, and her question is about the threads that would run through the visits. Was each visit a separate thread, or were they sort of woven together in some fashion?
So when I talk about threads, let me go back to what we tried to do was weave that content into each session. So every session would have a thread that was on child development. Every session would have a thread on the goal setting and aspirations. Everyone would have some content or a thread on positive discipline strategies, and then everyone would have this 15 magic minute play session training, because our belief, and I think the adult education theory supports it, is that you really need repeated exposure to a message to assimilate it. And I don't think 4 sessions is enough either. I think it's a very low intensity intervention. But the cafecitas then are a place that they can be reinforced, so you reintroduce those topics over and over, and oftentimes the parents ask for more. So it's designed that every session covers all 4 topic areas. If a group like LA Care is interested in something like pediatric obesity, then we either do that as a separate standalone module, or we try to weave it in as a 5th thread into the session. You can only probably fit 1 more in just because of time limits. So you can do it either way with the pediatric obesity. They wanted a standalone module. I probably would have tried to weave that in as a 4th thread to each session so that the parents were exposed to it each session.
That's great. Thank you very much. I have a question here from Rosa Zavala. How often do the promotoras do home visits, and for how long? I assume she's meaning how long is each visit?
So the sessions, the home visits run about 2 hours, and they go, the ideal would be to go every week for 4 weeks, but we actually have found that it's quite difficult to get a consistent schedule with the home visits, because the moms are oftentimes, they may be doing like cleaning house for somebody in another city, and so if they get a call, they just have to go. And so they don't oftentimes have a predictable schedule, so we can set it up, but it's not a no-show rate, I guess, when it's a home visit, but the kind of no-show or not completed visits are fairly high. So, but the ideal model is once a week for 4 weeks, and then the mom starts participating in the cafecitas once a month. And then if she's somebody that really either needs a lot more support or wants to get involved, then she would go through training to become a volunteer Madres. And we actually give them these pink T-shirts and a really cool little bag with this beautiful image, which is actually from an Orozco mural. And I'm sure I'm not supposed to be using it. I'll have to change it at some point.
I'm laughing. That is a beautiful image.
Isn't it gorgeous?
It does look, yeah, like something.
The moms love that. We have bags with that in, on it, and they really love it. And then we give them, like a little, many of the moms come from a religious tradition from a Catholic background, and so we have a little angel, a parenting angel, which they put up on their desk, and that becomes kind of a visual trigger or symbol to them, or up on their countertop. And that helps remind them of the Madres on Madres lesson. They have homework between sessions that they do. Very simple, usually visually. It's like tracking their 15 magic minute play sessions, because we ask them to do that at least 3 times a week. And what we find is the moms actually start doing it every day, and then they start adding other kids, which is better than I've been able to do.
That's great. Are there any other questions? Please type them in the chat box. Again, this has been very informative. I had a more detailed question about the distinction between time in and time out for older and younger children. Can you speak to that at all, Lindy?
I'm probably not the right person to answer that question. It's been a number of years since we developed this program about 4 or 5 years ago. And so I'm not up on the latest on what works with whom and where. The only thing that I can share is that this program that we adopted, and the moms actually looked at it and helped pick it themselves, was commercially available, and I think it's called 1, 2, 3 Magic or something like that. And it just had very consistent, easy to understand rules for the parents, and that's what we were focused on. In terms of what's the more effective strategy, I can't. I'm sorry, I can't address that very well.
I have a question from Elizabeth Ruano, who's helping me with this, and whose help I am so grateful for. Did you ever make an effort to teach these skills and provide this information to licensed caregivers? Is this a method for reaching them, or do you feel it's more relational?
I think it could be. Are you thinking like nurses or social workers or
no,
child care providers
who get a license?
The child care providers?
Child care, yeah.
Yeah, no, I think it would be, certainly in our environments, it would be very appropriate. Most of the child care in our environments were informal, and we've never used it with licensed care providers. So I don't know how it would work with them. It's really focused around improving that that mother-child bond. So probably it would have to be modified a bit for the child care provider, but maybe not. I don't know. It depends, I guess, how many kiddos and what kind of relationship, if it's a long-term setting or short-term. But certainly the play sessions and the positive discipline strategies. A lot of times the grandmothers will be delivering the child care, or the neighbor, and training them would make all the sense in the world. We've just not done it.
Take these last 2 questions real quickly before we sign off. Jairo Hernandez, one of our coworkers, asks, how and what level are dads involved? Is that going to be a separate program that you're planning?
Yes.
Or could the dad just participate instead of the mother in the existing program?
Yes, it'll be very similar. I think we'll just probably change the name a bit, and then add a few more for the father's role in the family. A lot of the concepts around respect and the hierarchy in the family, there's some cultural pieces to that would need to be woven into this. We have done this with, I think we had 9 dads that just insisted that they be a part of the program, and they all loved it, and it was quite effective. But of course, these would have been self-selecting dads. And so with just the general dad audience, I think you're going to have a bigger buy-in about, what is the father's role, and why should a father be learning these things, so that they actually, again, have that sense of themselves as having a direct role in the parenting, and then also the urgency and need for a particular approach to it. And I have a feeling that's maybe a little more difficult to deliver to a father, because of role definitions in these families than probably to the mom. You know, what we know in healthcare is when you tell a pregnant Latina mom that the smoking is going to hurt her baby, that's the last cigarette she smokes. It works a little differently, I think, with the dads because they see their role being more outside the family.
Interesting. Final question from Kathleen Adamson, who's the Executive Director of the YWCA. She asked about if you've done any work with Head Start. Would you see that simply as a method of recruiting parents, or is that a way to train? Again, I know you mentioned the importance of the mother-child bonding. Any thoughts on the role of Head Start in furthering this work?
Well, one, I love Head Start, and two, it would be a program that you could very easily train Head Start folks in, and then they could train parents that they're working with, the moms. Or it could certainly be an additional service that they could refer out to or incorporate in the work that they're doing. But it really would be kind of a train-the-trainer model where the staff are then training the parents in these things, right?
Right.
So, and the way we train the promotoras, they actually get a certificate in Madres. They don't in being a promotora because you just arrive there. And they've already gone through training as what it is to be a promotor. So they get kind of a specialized training in the Madres, just like they would in diabetes or asthma.
Well, Lindy, I want to thank you so much for a very informative presentation, and we had a wonderful audience, so I'm most pleased about that a lot of folks got to hear this excellent presentation. So to wrap up, I will send the CDC meta-analysis, that CDC parenting overview, to all the participants, and this will be available as a recording to those who have registered. And so if there are folks who missed it, who are obviously not listening right now, they will be able to go onto the ReadyTalk website and hear this. I'll also put a link to it on our Strive website, which is at the Monterey County Health Department under the STRYVE program. So for that, I want to thank Lindy Knox, Dr. Lindy Knox, for an excellent presentation, and hope that all of you have a great day.
Linda, thank you so much. It was great to get to join you guys for a bit.
Oh, thank you. It was just marvelous. Thank you.
Take care. Bye-bye.
Bye-bye.